Good morning, everybody, and welcome to our presentation on the best ideas on the direction of healthcare. I am Robert Fuller. I am a partner at the law firm of Nelson Hardiman. We are about a 25-lawyer healthcare boutique located on the west side of Los Angeles. We have a nationwide practice, and we represent healthcare providers and the people who do business with them. I am head of the corporate transactions group in the law firm. And with me today is my partner and firm founder, Mark Hardiman.
Good morning, everybody. Mark Hardiman here. I am also a healthcare lawyer with Rob. My specialty is in fraud and abuse, government regulation. And we're here today to give you our best thoughts about the impact of the current COVID-19 public health emergency in terms of likely macro trends that are going to affect your practice, whatever area of healthcare practice you're in. And we're going to try to do a little crystal ball viewing with respect to our best assessment of some of the macro trends that are likely to impact all of us, and hopefully provide you with some insight that will allow you to make the necessary adjustments in both operations, finances, and government regulation that we believe are going to be impacted permanently. You want to talk a little bit about that, Rob?
Yeah, why don't we hit the next slide just to get a setting on, well, there's disclaimers. It's not legal advice. Next slide we go. Where we are today in setting the stage, it's actually kind of a propitious day that Pfizer published this morning its initial data on phase 2 trial of its vaccine candidate. And it had really good results with respect to the comorbidity of side effects and so forth, as well as efficacy in the amount of very specific antibody neutralization titers, which is different from general antibodies. And also they are verbally saying that they're going to publish some T-cell response as well. And that is probably the more important of the health effects of the vaccine, because as we saw in studies recently coming out of China, the life of the antibodies with this disease does not seem to be very persistent. So without getting into the complexities of the immune system, the vaccine looks promising as far as the development goes. The problem is going to be deployment. Deployment may take up to 2 years. Most vaccines are two-step vaccines. Pfizer is huge, and it is only saying it will have 1.2 billion vaccines manufactured by the end of 2021, which means 600 million people, which is less than 1/10 of the population of the world. And it's, giving a scale of how long it's going to take to get everyone vaccinated, assuming there are 4 or 5 different manufacturers, large scale like that, it's going to take 18 to 24 months of vaccination. So we're going to be living in the current situation as we are, for the next 2 years. And so the issue is, what is going to happen? And as we've seen in the United States, there's a political debate on whether we need to be very safe from a health standpoint versus, how to economically move forward, whether the government can finance the economy for a while, or whether we have to reopen and try to engage in behaviors that are safe, such as social distancing and masking. And then there's a large portion of the population that's been triggered not to wear a mask. So, the issues are going to persist, especially in the United States. And, as we see, we've had openings in many states, and now that's been followed by some closings. And I think the initial question is going to be, how persistent are we going to be in these changes? And that brings us to our macro trend number 1 we'd like to discuss, which is our assessment is the world is not returning to 2019. The patients are not going to have the same expectations of you in getting healthcare, and the way healthcare delivered is going to be very different. And we do see that change in one spectacular way, that folks who've gone through a similar situation have adapted and adopted behaviors that kept them very safe this time around. And I'm speaking of the example of Hong Kong versus New York City. Very similar in size, very similar in density, although if you read the math, New York looks a little more dense. I can tell you Hong Kong is way more dense because the occupiable land there is just the thin ribbon around the waterfront. Tai Mo Chan is a giant mountain in the middle that isn't at all developed. When they need more land in Hong Kong, they spill out into the water and dredge and develop that way. So the density is the highest on earth. New York City, with American behavior and habits, had 17,000 deaths to date. Hong Kong, who was victimized by the SARS epidemic in 2009, emerged in 2009, and SARS in 2004, had 7 deaths. Think about that. Super dense, similar population sizes, 17,000 deaths for Americans who didn't take precautions, and then the Hong Kong residents who were out there protesting and everything else. It's not like they stayed home. 7 deaths. So it shows that human behavior does adapt. They've been scarred before. And so that leads us to believe that there will be, winners and losers depending upon how you adapt to the new world, and that the new world is definitely going to be new. We're not returning to 2019.
Rob, in terms of the impact of the vaccine, did the Pfizer trial study provide us with any insight into the efficacy of the vaccine in terms of longevity and impact on reinfection?
That was my brief reference to the T-cell reaction that they haven't published yet. So the vaccine data that was published this morning shows that on a neutralizing titer basis, which is not all the antibodies, but the ones that really do attack the virus, it was 8 times more strong than convalescent plasma drug. So that the human body's own response on people who've gone through COVID and survived produced a certain level of titer in response. And then the vaccine produces 8 times that effect. So we know that it's a strong vaccine. The feeling is that the vaccine produced antibodies in the body will be longer lasting because that's how they're designing the drug, but there's no assurance of that. Whereas people who've actually had COVID probably have way less immunity than they would think. It seems to be a 8-week massive decline in antibody titer presence in people post-infection. So the answer is we don't know entirely yet. They're designing it to make sure that it is a lasting titer. And the other good thing is that the other important part of this immune response is the T-cell response. We haven't seen that, and if that is persistent, and we know it's persistent for a lot of reasons, and if that can be induced by the Pfizer vaccine, that would give you a lot of confidence that your chances of getting sick and then the seriousness of the sickness, if you did contract it, would be way limited compared to someone who was not vaccinated. So they are hopeful on both fronts. Again, the timing on this, they announced their first basic small data set today. They're publishing in a journal next week. They've got more data coming out, but this is just phase 2. There's a whole phase 3 study that has to be done. And then after that, there's manufacturing deployment. If they start deploying in even this fall through emergency use authorizations, it's going to be a year to 2 years before everyone who wants a vaccine can get a vaccine. So the prevalence in the population is going to persist, going to continue. And we think that as more and more light is shed on what behaviors really do prevent the spread of the disease, that while we're going through this next period, people are going to adopt and maintain that. And we'd hope that social distancing, thorough cleaning, and the wearing of masks would catch on in the United States. Apparently, we're not that smart. So we're probably going to have a longer and more serious course of the virus, as shown by all the charts, than Europe or Asia.
Right. And the reality is, you know, regardless of the impact of the vaccine, to your point, the United States population is not exactly homogeneous with respect to its healthcare behaviors and following direction, as we've seen very recently with the marked rejection of a lot of the recommendations from CDC and to a lesser extent the federal government, who is giving obviously mixed message between the healthcare agencies and the president's view of things. But the reality is there's a significant part of the population that is going to be resistant to the vaccine. I've seen figures in studies that, you know, the anti-vaxxer community is actually much larger than one would have rationally thought. And there's studies been done recently that, you know, polls that have indicated that up to 30% of the population is going to be resistant to actually taking the vaccine. So the bottom line is, whether we're 2 years out with respect to the implementation of the vaccine, our reality is going to be COVID-19 for many, many more years as the population adapts and takes in its lessons from the experiences we're going through now. So yeah. This is to Rob's broader point. It's just like when the rules of political discourse change, it's a dream that we're going to return to normalcy or what we believe was normalcy. Things like this have permanent impact on people's behavior.
Yeah, I kind of see that as Darwin having his way with the anti-vaxxers, though, but that's just my own cynical view of it. But you're right, Mark. There will be continuing. It will be just like seasonal flu. You probably are going to have, over the course of your lifetime, the necessity of getting multiple vaccinations for COVID-19, just like the flu. We can anticipate, like other coronavirus, it will mutate, and the mutations won't quite be covered by the old vaccine, so they'll have to update the vaccine. And it's a constant, the scientists trying to keep ahead of the mutations in the virus. And yesterday, of course, the World Health Organization announced that they found a new novel H1N1 flu in the swine population in China that has every bit of chance to be a dangerous flu coming up. So stay tuned. We have a lot of infectious disease that's going to go around the world as long as we have airplanes and boats. We're going to be sharing it worldwide. And people are going to have to be a little more attentive to their personal hygiene and in terms of washing their hands a lot, no matter what happens. But what does it mean for the healthcare provider? And that's our macro trend number 2, which is people are just, not everybody, but a lot of people, a good chunk of your market, a lot of your patients are going to be reluctant to go to a facility. Their expectations are going to change. Their behaviors are going to change. So there'll be some delayed demand where everyone will want to go back and get their elective surgeries done and so forth. We think over time, there's going to be increasing demand for medical and other healthcare services to be provided through a what we call non-touch experience or non-contact experience if you're getting your pizza delivered, I guess. And this is going to be true of healthcare. So, for instance, on some low-hanging fruit kind of things that we see, where we think that the technology deployment is going to accelerate. We think that things like waiting rooms are a thing of the past. You're going to stay in the parking lot in your car till you're summoned by your smartphone. We think that hospitals are going to have multiple staging areas for assessment of people coming into the hospital before they're allowed to the ER area. We've seen some hospitals modify to have COVID wing and non-COVID wing, or COVID untested versus COVID tested folks. So there's just basic flow. We know how to do this. Most pediatric practices have a sick kid entrance and a well kid entrance. And so it's going to be something for all facilities to consider, is the staging of how and when they allow patients in. Do they require pre-testing? Of course, in the current function, they do, because COVID's prevalent. But what happens when COVID prevalency reduces? Because of its danger and its deadliness, we think that you will still have the need to have pre-visit to the facility testing and assessment. You're going to get fever gunned everywhere you go, whether it's an airport or an NBA game or going to our offices here in beautiful Westwood. So there's going to be this continual assessment of current health of the person before entering a facility, and you need to plan on that for your own facilities. Now, what that means is a lot of work that goes on in facilities now. If you're not actually having to put hands on the patient or cutting into the patient or doing some sort of invasive procedure, practically everything, we believe, is going to be moved to a digital telemedicine offsite interaction with the patient. And chief among those, we think, macro trend number 3 is that we see a large portion of the population moving to personal health monitors, not just a little Fitbit watch, but devices that are coming online that have like ICU monitor level of data coming off the patient on a continual basis. O2 sat and heart rate and EKG and blood pressure, respiratory rate, all those things that get monitored. We think that that monitoring is going to be more prevalent as the wearable device is able to come online and better and accurately measure that. So the question is, who's watching it? Is it going to be a happy little alert that pops up, you're having a heart attack? No, we think it's going to go actually further than that. There are going to be services, and your practices have to anticipate this, if not participate in, for remote patient monitoring, which you can do with sick patients now. But we think there's going to be a very strong demand in the healthy patient population for a clinically trained person to at least be alerted if something on the monitor pops up in a data point that is considered out of normal. So what we have now, we've described in the past in our past writings, spurred by the ACA, has been more and more outpatient, more and more post-acute, go to the home, more and more remote monitoring, and that's in the case of sick patients. We think that's going to leak over to healthy patients, and we think the technology is in fact supporting it. So right now we have a battle of case managers. Who controls the case managers who have the contact with the patient? Is that the IPA after discharge from the hospital? Is it the hospital? Is it the hospital working with skilled nursing? Is it the insurance company? All of these players in the marketplace, as you know, are battling over the case management question because that A, controls costs, and B, is the customer contact point with the patient. So now introduce a much larger population of folks who really aren't post-acute, but will have access to world-class monitoring. And we think a large portion of those people, especially in the post-COVID world, are going to want to know the second they have a spike in their respiratory rate or the second they have a spike in their fever. One thing that happened recently that shows the value of this is that the PGA, the golfers, all had a very sophisticated monitor attached to them in their run-up to the tournament that they started 3 weeks ago. And one of the golfers was alerted during a practice round that their respiratory rate was just 3 breaths per minute over the baseline. And gee whiz, why don't you get a test? Well, Nick Botany felt fine, had no issues whatsoever, but the machine was telling him his respiratory rate was 18 rather than his usual 15. He went and got tested, and sure enough, he was a COVID-19 infected person. And that, forced him into quarantine, and so he's fine. But it showed the efficacy of the technology in real time, that even something as subtle as a slight increase in respiratory rate monitored by a Fitbit on steroids was the key to the clinical people monitoring him, that maybe he should be triaged for further examination. And because of the continuing number of anti-vax people, because of the continuing nature of the mutation of the virus, and because of the widely larger group of sensible people versus the anti-vaxxers, let's call it 70-30, we think the demand for real-time continuous monitoring is going to be a trend that will take off, and that will in turn change the nature of your contacts with your patients.
And it's not just a function of COVID-19. I mean, COVID-19 has impacted that broadly in terms of, in our view, the education of large segments of the population with respect to what I call sort of remote consumer habits. I mean, everyone is realizing that the convenience of just sitting in your bunker and ordering up Amazon, Grubhub, etc., extends to everything, and the technology is there. I mean, COVID-19 is going to push forward in terms of the change with respect to the delivery of healthcare. But already pre-COVID-19, as everyone knows, telemedicine, there's been a lot of venture capital going into telemedicine. It's been so far regulated or somewhat suppressed into the area of, aches and pains and flu and the like. But technologically speaking, as Rob said, the technology for sophisticated monitoring services is there. I mean, I remember, 15 years ago, whether there was a big debate about what you could do remotely, and there were pages of specifications for video as to whether a dermatologist could do a skin review and what resolution was needed, etc. Well, we all know now that your average member of the public, even though there's surprisingly low internet penetration into certain communities, your average member of the public now is conversant and has become more conversant with remote technology during COVID-19 in terms of getting used to navigating remote services. And so that is just going to extend, as Rob said, to convenience, not just safety, but to convenience. And the monitoring technology is definitely there. I mean, you already have companies that monitor both through artificial intelligence, and then there are alerts with respect to Holter monitoring and cardiac monitoring. You don't have to call in anymore. The monitors you have actually buzz the data and set off an alert that will get a human being on the phone to you or emailing you. And so it's going to be technologically a natural extension to what Rob mentioned, which is personal health monitors that are not cumbersome and are small and getting smaller, but provide a level of technological monitoring that will be attractive to patients because they'll believe that it's effective, and it will be effective, and it will also be much safer than going, in our view, their perception, than going into a healthcare facility, including a physician's office.
Yeah, and so some additional implications for operations of the show here is that we're effectively reversing the patient flow of the last 70 years, where a centralized community hospital or university hospital was the destination, and patients were triaged towards there, from their doctor's office to the ambulance to the ER. And that was just how you handled everything, whether you had the sniffles or whether you had a broken leg or were having a heart attack. And it was, I was a hospital administrator for 11 years, and it was one of our big community outreach items was to make sure people knew that we were there for them, for their health, and that, we had all the bells and whistles and tools and toys and lots of great doctors, and please come in when you ever need healthcare services. Now the message is kind of reversed, that stay away unless you absolutely have to come, and let's do this digitally. Let's do it over the phone. Let's do it through telemedicine now, and even the hospitals are having to do that. We know locally one hospital cut out all of its elective surgeries, took a huge financial hit, had to furlough lots of people, and expected a very large COVID population based on the numbers. And for whatever reason, the seriousness of the COVID infection in Los Angeles didn't quite meet what was being expected back in March, and they only had 1/6 of the patients that they were anticipating. So, that's a short-term financial disaster for the hospital, but I think it is kind of a warning for the rest of the world that these behaviors are going to fundamentally change your patient population and when, if you are a facility, patients come to the facility. So we think that telemedicine will become the norm even for hospital kinds of matters, unless you're doing an actual, physical intervention. Patients preferring to stay away because of infection travel and waiting room delays. No one wants to wait in an ER. And then the other area we think is going to be profoundly changed is mental health care delivery. It's been the teaching for psychologists and MFTs and licensed clinical social workers for years that actual interaction with the patient, is very key to having the ability to real-time assess the patient and their reaction and how they reflect and have their presentation and all the non-verbal clues and body language and so forth. And you get some of that in telemedicine. It's not quite the same, but the studies are showing that the effectiveness of therapy over the telemedicine model is virtually the same in most settings for what I'll call non-acute mental health as it is in actual face-to-face settings. And so the ability of a single mental health provider to provide care is going to be expanded through their ability to provide telemedicine for the therapy sessions. And this in turn raises all sorts of technical issues that the smart IT people are solving with respect to confidentiality and the security of the transmission. And there's a certain amount of empathy that can be expressed on the screen that isn't necessarily the same, but nevertheless, when we look at large numbers of disease outcomes, the people get better and improve just as well through telemedicine therapy interactions as they do through face-to-face interactions. Now, as we mentioned, technology is going to drive this with smartphones and sensors and heightened ability to monitor the body. Implants and other devices can remotely monitor functions and outcomes, and people are getting more used to that idea. But we also believe that the return of the house call is maybe on the horizon for at least the nurse or phlebotomist or someone who has to put hands on or collect the specimen. That is also a distinct trend that we'll see with larger IPAs having to deploy people, not to wait for people to come to the doctor's office, but to send the nurse, the phlebotomist, the physician assistant out to the community to do the hands-on data collection and sample collection and so forth. So
yeah, and there's a lot of development in that. I mean, I was surprised because I took a quick look at what's available on home tests, and I don't mean home health testing. Already, various companies are deploying what appear to be effective tests that are basically blood spot or finger prick tests, and you can expect that the amount of blood that is needed to diagnose or run a CBC is probably going to take a while for it to just be a pinprick, but it's definitely headed in that direction with respect to blood sugar levels. There are home test kits for hepatitis C based on finger prick, and obviously a lot of labs are now offering basically mail-in urine and stool specimens that you can just take yourself at home and then mail them in a secure container. On the implant front, there's all kinds of developments in terms of not so much for patient convenience, but it is potentially going to avoid complications where there are sensors being developed in things like hip replacements that actually monitor temperature, and as a result, monitor potential infection on whatever implant is being put in remotely, so that the physician gets data that would indicate much earlier whether the patient needs to be checked out personally and whether there's a potential infection developing. So once again, the technology is really just jumping forward in terms of supporting the macro trends that we've identified.
Yeah, one other matter for operations that we think we addressed the waiting room and the different locations for brick and mortar locations, but we think supply chain consistency is going to be way highly valued. So McKinsey and everyone on the planet came and visited you if you were a hospital administrator 10 years ago and told you you had to change your ways from having 6 months supply of everything on hand to just-in-time inventory. And it turns out for a pandemic, that's about the worst thing you could possibly do. So there were hospitals who didn't do that, like Harvard Beth Israel, who had warehouses full of supplies and were able to supply most of the hospitals in Massachusetts with the PPE and the other supplies. And there's a lot of hospitals caught off balance on this trade and did not have access to the supplies on a consistent basis that was needed by their staff. Now, so you've got ISO 9001, which supposedly allows customers to integrate better with their suppliers, know their suppliers better, develop the relationships, and have the assurance of quality of the supply. But you have most hospitals in the country being a member of one or more GPOs, and the GPOs kind of control the action on the purchasing. They're sort of very beneficial financial middlemen, but in terms of actual guarantee of supply and managing the supply, the GPO performance, I think, has been miserable. And that's whether you've got a big GPO that you play with or you've got a regional one. By and large, they were caught totally offsides on this trade. And so I think hospitals, most good hospital administrators I see and I talk to are got that number one on their checklist for getting addressed in the coming months, which is we need to take control of this GPO, not for contract negotiation purposes, but to make sure that there is a warehouse that has PPE in it, that has Ringer's lactate in it that I can get my hands on, that has all the supplies necessary to stand on our own. I mean, one of the biggest disappointments that we've seen in hospital land is the total lack of support from the federal government that you would have thought was coming, and it never materialized. They did very little. They tended to actually interfere. There's stories which I basically can confirm where they would hijack trucks and planes of supplies headed for hospitals and take them to FEMA warehouses in the name of the federal storage, and that's, to me, as a former hospital administrator, it's totally unacceptable that the hospitals were not able to protect themselves in that way. So that's going to be changed, and I think politically that will sort itself out. Over the next few years, as people look back and Monday morning quarterback what we did right, what we didn't do right in the pandemic. But I think hospitals are going to be very eager to fundamentally change how they interact with GPOs, the amount of inventory they keep on hand, their access and security of supply, and that's not just make it American. That's having a warehouse with the actual FDA-approved equipment already in it, and be assured that in the event something pops up, you have first call on that, and that if you don't have it on site, you're going to get it trucked to you without an interruption. And I
but self-sufficiency is expensive, right? But you're saying your view is that the trend that led to hospitals not having stuff on hand in terms of cost containment is going to be outweighed by the reality of you need to be self-sufficient for at least a certain period of time, because you can't really depend on the feds or the state government to fill the hole on a supply chain.
That's true.
I mean, they're no better at it than you are.
No, but at least you know where you are, and you've got OSHA responsibilities to keep your people safe, and not having enough PPE is frankly must be the most distraught, horrible feeling for any hospital administrator not to have the equipment. And then I've always said hospitals aren't real businesses, so some business concepts work great. Just-in-time inventory for hospital is horrible. Doesn't work. They need to have some resiliency, some ability to be able to stand 60 days on their own or 90 days on their own without reliance on outsiders. And maybe the US made masks can be a little more expensive, but at least they're here. But those are all trends that we see, and we think hospitals are going to rise up and take back control of the supply chain. Next. Okay, so the issues that are going to come from COVID on the finances are probably their own 3-hour webinar. But we will highlight what we think the main trends are. The first trend is, and this was kind of put in place by the ACA, but like a lot of things under COVID, it's been accelerated by 5 years, just out of practical reality, is that there's going to be a tremendous trend to pay all providers at all levels Medicare rates, under either Medicare Advantage kind of structures, and whether or not there's a Medicare for All law passed. And what you have here is a structural disconnect, and California I can speak to, I deal with it every day, that, you know, as a hospital administrator, you had to try to get 4 or 5 times your marginal cost of care out of Blue Cross because the governmental programs didn't pay you enough. And then if you were, especially Medicaid, and if you were on your game and you were really cost containment inclined, you would try to run your hospital on the base Medicare payment. That if you could run your house on Medicare and get a little more out of Blue Cross to pay for the losses in Medicaid, that was kind of the formula that you tried to work on. So the bad news is a lot of the insurance companies, as we know, have gotten out of the risk business. They've transferred the insurance through HMO and other devices to the providers. And over time, they have been very aggressive in trying to push the payments down to just, you know, a slight margin above marginal cost. And that's the bad news. That trend will continue. The good news is I think there's also going to be equal trend on getting Medicaid to pay more of its fair share, because the societal cost is cheaper if Medicaid pays more of its fair share versus the health premium paid by employers. And, you know, we don't have time to debate the full policy of whether employer-based insurance is the right structure or not. But the bottom line is that regardless of the structure, the numbers are going to ever more tend towards a Medicare basis payment. And so the word to the wise is you need to get your house in order to make sure that you can run financially successfully based on a Medicare level of reimbursement. The other huge piece of thing that we can't, you know, get rid of from our minds on COVID is the money printing machine that's gone on and the giant holes that have been put into local and state budgets, and then the federal multi-trillion-dollar support programs. I mean, those are all at some point going to have to be adjusted. And we think that the most likely scenario for a period of 10 or more years is going to be increase in tax rates at all levels. Your sales tax locally is going to be higher. Your tax for state income tax is going to be higher, and your federal income taxes, at least on the corporate side, are going to be higher. And we just have to recognize that and plan accordingly. Third is the pre-COVID trend of looking at the percent of healthcare taken up, of GDP taken up by healthcare that was unsustainable even before COVID. Well, we now have had the light shown on it that it's very unsustainable. That the amount of money in the system pays for a certain amount of healthcare. It's not widely accessible. There's going to be market disruption occasioned by the inability of the country to finance further expansion of healthcare as a percent of GDP. And those are just macro trends that have been in place, and we think all three were accelerated by the COVID. Next slide.
So I just want to briefly comment. I mean, again, it's what we're positing is that COVID-19, the public health emergency, is going to accelerate a lot of things that are already in play. And Rob's point with respect to the model headed towards, you know, Medicare and Medicare rates for commercial plans, it was already in play before COVID-19, but is likely to really be accelerated. People don't realize that, you know, now it used to be fee for service was the main coverer of Medicare patients. I think it's like 75% of Medicare beneficiaries are now covered by Medicare Advantage plans that are not run by companies that were set up to be Medicare administrative contractors. These are large, all the large commercial insurance companies are now Medicare Advantage plans, and it's just going to be a natural shift to integrate the Medicare Advantage reimbursement with commercial reimbursement by continuing the attack on reasonable and customary charges as a meaningful metric for reimbursement, and thereby decrease the amount of money they have to pay out. But it's clear that given the impact on the overall economy by the current public health emergency, that we can expect a dramatic acceleration of the large commercial insurers pushing those rates down towards what they pay out currently on Medicare Advantage plans and fee-for-service Medicare.
Yeah, that was all started by the ACA, and now it's just going to accelerate. Now, so if we go by our theory that margins are going to be compressed, discretionary incomes are going to be down, you're going to have a lot of spurring of what we think macro trend number 5, which is M&A in the hospital space, especially, but at all levels of healthcare, actually. And this has been accelerating since the passage of the ACA. Once the computers were mandated, you had to have enough beds and enough patients in your system to spread out the IT costs that were mandated. And as the digitalization trend continues to leverage the benefits of that digitalization, you're going to need larger enterprises with more hospital beds under management and more patients in your system. So we think that both hospital consolidation, horizontal mergers, and also acquisitions of lower levels of care, vertical mergers, will continue at an accelerated pace. That's just a natural function of the combination of the digital expansion and the margins going down. So the kind of nuances in some of that are going to be the existing trend that new doctors don't really want to be independent practitioners, but they want to be employees. We think that this will scar many of them from going into independent practice who might have otherwise done that. We think practically the entire next generation of providers, doctors and others, will accelerate the trend to becoming employees, so that we think there's going to be a large pool of clinicians available to be hired by the consolidated larger healthcare corporations. Now, the FTC has kind of made some noises about, well, the old merger rules are going to apply. We're not going to allow too much market concentration. That, I think, is going to go by the wayside. I think the reality is that without the consolidation, given the margin compression, given the taxation increases, you're going to have, the potential for failures absent consolidation. So to preserve the assets to the market and preserve the access, I think macro trend number 5 is inevitable, that there's going to be consolidation. Next slide.
And the reality is that that's going to have an impact on just, the entire delivery model of at least physician care on the employment front. The doctrine of corporate practice of medicine has already been substantially eroded. But when you've also got physicians who are now pretty reluctant, or are likely to be pretty reluctant to take the risk of running their own practice, and then the moment there's a public health emergency like just happened, going into the red almost immediately, given the fact that they're a small business, you're going to have all kinds of shortages of individual, especially primary care physicians, who are really struggling to make income, and you're going to have corporations stepping in, whether they're physician-owned or physician-run, to scale up the delivery of primary care services and intermediate care services as well.
Okay, so we've run about 45 minutes here. We want to leave a few minutes for questions at the end. I just want to touch on government regulation implications of COVID. The easiest one to see has been CMS's waivers of many aspects of care and reimbursement during the COVID public health emergency. And we think that a lot of these experiments have given CMS confidence to make these changes permanent in some instances. Matter of fact, 2 days ago, they issued a rulemaking on the home health area. I didn't expect that to be first, but it was, making the COVID waivers for home health, they're proposing to make that permanent. Now, they're not exactly saying sub out in-home visits for telemedicine, but they want to keep the regulation, the emergency regulation in place, because they've noticed it's a very substantial multiplier and good addition to the required in-home visits, and that they're willing to pay for not just the course of 6 or 12 visits, by the nurse in the home, but an additional 6 or 12 telemedicine contacts on top of that, and that makes for better patient care, they notice. We could have all answered duh a long time ago to that, but they didn't want to necessarily have to pay for that. But the outcomes are such that if you give 6 telemedicine visits and 6 in-home visits, you curtail the care needed very much more quickly than if you went with just 12 in-home visits. So it's better patient care. It's probably cheaper in the long run. And we expect to see more and more of this for everything from glucose monitors to the in-person requirements for physical therapists, occupational therapists, language pathologists. We think that there's going to be expanded eligible telemedicine services, as we mentioned earlier, for psychotherapy, ESRD, regular evaluation and maintenance of physician appointments. And so we think that a lot of these areas that temporarily were waived by CMS are going to become fact of life. And again, that's leveraging the digital transition, but also now, CMS has indicated willingness to pay for it. And since most commercial plans follow CMS rules on reimbursement on when something is eligible to pay for, we can expect a whole slew of new CPT codes coming out in the next few years, covering the remote patient monitoring, telemedicine encounters, and so forth. And we think that is going to be the permanent state of regulation eventually. Now, there's a dark side to all this. Next slide. This is more of my partner's area, which is with all these new telemedicine and waivers and go ahead and do documentation light. We've kind of noticed out there's been a lot of fraudsters come to town. There's always opportunists. Mark, why don't you address what you've seen out there?
So yeah, it's already started. The digitalization of healthcare there's always people out there that are ready to take advantage of new opportunities with respect to fraud. The reason telemedicine creates greater opportunities to commit fraud undetected are fairly obvious. You now have a larger patient pool with no geographic limitation in terms of being able to deliver care. If you're planning on committing fraud in a brick and mortar place, obviously eyebrows will raise if you start submitting claims for people that live hundreds of miles away. That, of course, is not the case with telemedicine delivery. One of the things with respect to telemedicine that a lot of boards have been concerned about is that it's far easier to establish a cursory, if not non-existent, physician-patient relationship, which is normally the predicate for being able to order various services and submit claims for them. If you're doing it remotely, it's much, much easier for telemedicine fraudsters to reach out to a much larger population, including through boiler room marketing, where, I've seen schemes now where they're built around mass marketing and contact with patients, initially by non-professionals, usually offering some type of free service, and then in the next breath, offering to set up a consultation with a doctor that is very, very brief, and then that leads to the ordering of services based on a 10-minute call and the submission of claims, not just for the initial consultation, but for a bunch of different things. So fraud is going to be a big problem. And at the same time, even if you're not a fraudster, you can expect more regulatory oversight and demand for new and specific documentation with respect to your provision of telemedicine type of activities. So the documentation that is going to be required is likely to change. And there's likely to be much more telemedicine specific requirements put out both by the government programs and by commercial payers. Even though they're realizing that this is a trend you can't reverse, they are going to try to put breakers on what they're going to be concerned about is going to be a tsunami of fraudulent claims.
Yeah, so one practical thing is that most of your billing software is probably going to have to be expanded to include metadata so that the actual situs of the entry claim, the date, and who was signed on and so forth is not just something they can come get on a subpoena, but something that is submitted along with the claim and reimbursement, and that will be analyzed by government computers. So expect that the reimbursement is not going to get easier as these enforcement actions and then enforcement action mitigation steps are taken. Next. So one thing I'd just like to touch on before we finish is that the FDA has also done their best to try to stumble through and has issued emergency use authorizations for lots and lots of material. The one big trend we see here is that pooling big data on certain products is a very effective way to create an assessment versus testing. And I'm not talking about new investigational drugs or biologics. I'm talking about the efficacy of devices that are used, everything from masks to thermal imaging mechanisms. And there's got to be some updating of FDA procedures on getting the approval processes done. There's also going to be some proactive steps by the FDA to kind of monitor the market and either approve or disapprove products on an ongoing basis, just so we're not caught in a giant catch-up if we ever have anything like this ever happen again. So anticipate a fairly large increase in FDA regulations and process revisions.
Cover from liability, Rob. Yeah, that's an interesting one because that's going to have to be a legislative fix. I was watching the healthcare Senate hearing yesterday, and I think his name's Dr. Hahn, the head of FDA, was asked about, when there's accelerated emergency approvals, whether the FDA is going to provide any cover for liability for the manufacturers and innovators. And he said, look, the FDA doesn't have jurisdiction on that. We don't provide any cover from liability as an agency. So to the extent that that is needed, it's going to have to be a legislative fix.
Yeah, and we do anticipate that that will at some point be taken up and go through next. And I think with that, we are concluded and would welcome any questions that folks have. We tried to identify some big trends, covered a lot of ground, but that's where we see the world going. We hope to update these presentations as we go, and as new trends become apparent to us, we will certainly try to communicate what we see out there.
Right, and it's also not just a message of get prepared, but it's also a message of opportunity. As you have certain areas that are going to compress and reduce in size, as Rob has alluded to multiple times, the delivery of remote services and getting ahead of that in your practice area or your health industry area is going to be critical. And if you do, it's an opportunity for you as a healthcare provider to increase your market share by being ahead of the herd and the pack in terms of both having the technology available, but starting to market yourself as a forward-thinking remote healthcare provider.
Okay. We're getting quite a few questions. We'd like to first thank everyone for viewing this today and listening. We will try to get to all the questions that we can. And
This will be posted on YouTube.
yes, this will be posted on our website. If you need to go back and listen or you want to share it with people, visit nelsonhardiman.com and you'll be able to navigate to it. First question is, how's trend going to affect facility-based care? If people come inpatient, what measures need to be taken? We think that the biggest is going to be segregation of a screening mechanism. We mentioned briefly that hospitals, before you get near the hospital or admissions, you'll do most of the paperwork off-site. You will only be invited into the hospital after you've been screened. And we think that those blue tarp tents that you saw out in front of all the hospitals, those are eventually going to become actual brick and mortar buildings, and the flow of patients through the hospital is going to be through these fairly elaborate test and triage centers before you get in to the building. So we think that's where that's going to go. Another one, nursing training is being impacted if there's fewer hospitals and fewer opportunities. There's been a nursing shortage in California for 20 years. The ability of a nurse to assess a patient, their most valued skill by far, unfortunately is really a bedside endeavor. I think that like, elementary schools and everything else, the only short-term answer is going to be class size increase, and that when they make grand rounds and they do the bedside training, a lot will be digitalized, a lot of the learning will be book learning, but the actual skill of nursing to assess a patient is still a bedside issue, and with fewer hospitals and hospital beds and fewer people coming to hospitals, it's going to be more difficult for the nurses to get the training they need. There could be a change in nursing. I sit on a couple boards where we've discussed this anyway, that the nurse practicum and the nurse training maybe gets expanded to 3 years, but have 1 year be the science and book learning, and then have 2 years of extended bedside training, and maybe that's just how it's going to have to work.
You may have opportunities though, right, in terms of nurses, opportunities notwithstanding the shortage, but in the remote monitoring world, where I can see room for nurses being an integral part of remote monitoring operations on a lot of the remote monitoring that we've discussed, at least as the first screener before it's escalated up to a physician or some other healthcare professional.
Yeah, but again, their assessment abilities really do take place at the bedside to get the full view of the patient and the full ability to assess. So yeah, I mean, they'll be very valuable people clinically in all these monitoring.
Group therapy, there's a question about how do we think this will affect addiction, mental health in relation to group therapy? Well, that's a good question, because I think what we said earlier with respect to remote therapy and its efficacy will hold true for one-on-one, but currently there was no waiver given by CMS for the offering of group therapy, in other words, Zoom therapy, in terms of a waiver for the in-person. So I think that as a reimbursement matter, the jury is still out with respect to whether the therapeutic impact of group interactions can be replicated remotely. I know for a fact that, obviously AA and NA did not stop during the COVID-19, and they immediately jumped into a Zoom environment, and I don't know, whether the participants felt the same level of support. So the short answer to that is, in terms of reimbursement, I think that will be the last therapeutic modality that will be reimbursed on a remote basis. Yeah, but it's probably headed in that direction as well.
One-on-one therapy is telemedicine headed and is
Yeah.
effective. Group is up in the air still. You're correct on that. We had a question about how are the uninsured or underinsured going to participate in the telemedicine revolution? Well, that's going to be a very substantial part of the political debate. It's more and more just not acceptable to not have people have healthcare. This is the beginning of a speech I used to give to the Rotary clubs when I made it, that you know, the waiter didn't mean to sneeze on your salad before he served it to you, but he needs the job and needs to pay his rent, and so he came to work even though he wasn't feeling well. We're all part of the same disease vector, and COVID has made that incredibly important point, that the disease, you know, doesn't check your Blue Cross card before coming by. And the more people who have access to testing and treatment, the better we are. So we've kind of forced the access on this one particular disease. But the broader political questions still remain, which is, you know, we definitely have multi-tier access to healthcare, and your American Express Platinum card and your Blue Cross Gold plan doesn't protect you from getting COVID. I mean, that's just the fact of the matter. And what would protect you from getting COVID is to make sure everyone in your disease vector had, you know, basic health care. And sorry for the political speech, but it's just, it's a matter of fact that the access needs to be better distributed however we get about it politically, whether it's still employer-based or some other formation of health insurance.
It's also an interesting question about, you know, whether hospital systems would have an economic incentive to encourage or in fact support some type of remote healthcare as a subset of their ER, because so many of the uninsured use ER as primary care, that if remote access to telemedicine was provided as some type of indigent care at some level, it would be complicated, but it actually could reduce emergency hospital departments as being, you know, a significant and very expensive provider of day-to-day primary care for indigent.
Where are they gonna get the iPad or the iPhone from?
Well, that's a good question. They may have to arrive on site just so that they don't tie up the ER. I was thinking more of sort of like some type of screening that doesn't need necessarily a live person. Yeah. But that's a good question. Good question. I mean, how would they access the internet? Yeah. They could go to the library, maybe.
Yeah. Well, so that's going to have to be our next webinar. Again, thank you so much for everyone for tuning in today. We greatly appreciate it.
Yes, and enjoy the weekend. Happy July 4th.
Happy Canada Day.